in the renal module is the renal system is fully responsible for most of the fluid compartments that we're going to be. And we have to know how we're shifting these things around in order for us to know what exactly is happening to our patient. So for example, we know that the total body weight, the total body mass is made up of 60% water. And of that 60% water, about 2/3 of that water is the intracellular space, and about 1/3 of that is in the extracellular space. And from that third in the extracellular space, we're going to end up with 80% being interstitial fluid and then 20 being plasma. So think about the 20 plasma is everything outside of the tissue wall, right? And then the interstitial space is everything, all the fluid that is in the tissue. So that's when you're having that movement, you have to figure out, is a patient third spacing? Is a patient having expansion of the plasma? Is a patient having are we pulling from the intracellular or extracellular fluid? So this is just to give you an idea as to how we are working. All right. So as again, the body is made up of 6% water, 40% non-water. Most of that water is found inside of the cell, and 2/3 of the body water is intracellular. 1/3 is outside of the cell or extracellular, and of that fluid that is extracellular, 1/4 of it is found in the plasma. So it is in our vascular system. Now, how do we move fluid from one compartment to another? How do we move from intracellular to extracellular? How do we move from interstitial to plasma? And that is based on really osmosis, right? What is the osmolarity? What does osmolarity mean? Anybody? What does osmolarity?
Doc, does it have to do with how like fluid moves from one place to the next? Is that the case?
It is, but I need a little bit more than that. What is osmolarity? When you osmo,
Water?
well, it is a solute actually. It's how much a particular it is the concentration of solute in a particular volume of liquid. All right. So when you're looking at plasma osmolarity, it's about 300 milliosmol. And it's very important you need to know that, because when you're going to give somebody resuscitation, for example, if you're going to give somebody like, if you're going to give somebody dextrose or normal saline, you have to know the osmolarity of plasma and the osmolarity of that solution, because if you give it and it has a different osmolarity, we're going to see what's going to happen, right? So fluid only shift if there's a difference in osmolarity between the compartments. So for example, if I give a patient 300 milliliters of a fluid that has an osmolarity of 300 millimoles, no fluid is going to move. No matter how much volume I give that patient, no fluid is going to move. The minute I change the osmolarity, then it's going the water is going to move to the space that has a higher osmolarity. Who don't understand that? You have to understand this, because if a patient come in bleeding and they go and give them something like that has a different osmolarity and they die, it's going to be your fault. So you have to understand this. So what do you normally resuscitate a patient with?
Normal saline.
Lactate triggers, but first what they give you, normally which one?
Normal saline.
Why do they give you normal saline? And what does isotonic mean?
They normally give normal saline because it's very similar to the proportion of electrolytes that's in the body. That's
correct, right? So that's why we resuscitate with that. And I'm going to show you some other instances where we do give patients, we give patients fluid that is not the same, that's not isotonic, for different reasons, right? So fluid shift. So loss of isotonic fluid from the intracellular space means that there is no change to the fluid in the intracellular space. Loss of isotonic fluid in the extracellular space means there is no change of fluid in the intracellular. So when somebody is bleeding out or hemorrhaging, they are only losing fluid from the plasma. they're not losing it anywhere else, right? Because the fluid is not going to move from the interstitium into the plasma because they still have the same osmolarity. As soon as they change it, that's where we have a problem. Now, sometimes when you're bolusing a patient, we give them months and months and months and months of normal saline, and we're not worried that we're going to change the interstitium or even the intracellular compartment of the cell. Because if we put water into a cell, it's going to, remember, osmosis is going to diffuse and it's going to burst, right? We are not worried about that because we're giving them something that has the same osmolarity, 300 milliosmoles, right? Now, it gets a bit tricky when we use dextrose. If we use dextrose, initially it's isotonic, but then the body is going to use up the glucose and then it's going to leave free water. And then that water is going to move now because the water would have a lower osmolality than the intracellular compartment. And as a result, it's going to move into the cell and then we're going to have a rupture of the cell. So that is why we don't just give dextrose as a we just don't give dextrose as a resuscitation method, right? And then mannitol infusion. When a patient has cerebral edema, we give them mannitol. Why do we give them mannitol? The mannitol is a very big sugar. And because it's so big, it increases the osmolarity outside of the neuron and it pulls water out of the neuron, and that is what decreases the edema. So that is why that's how we give the thing. If you give mannitol infusion to a patient, if you give mannitol infusion to a patient who doesn't have cerebral edema, you're going to kill that patient. They're going to literally dry out the neuron, practically. That's what it's going to do. Everybody understand this concept so far about the osmolarity, how we resuscitate. This is going to be following you for the rest of your life. So you need to know it, right? And a patient comes in, and you need to know how to resuscitate. And the nurses ask you on call, hey doc, what do we give the patient? We don't have any, we don't have no normal saline, right? You have to go and look to see if there's any lactated ringers. Although we don't prefer it, but you'd have to go. So you have to look for something that has similar osmolarity. What is the osmolarity of blood, of plasma? 300 milliosmol. I saw that question before, so that's why I'm stressing it a little bit, all right? Now, with all of that fluid we're talking about, how do we get rid of that? When we bolus a patient now, how do we get rid of all that excess fluid? Yes, it is not going into the intracellular space. It is not going in the interstitium. Where is the fluid going? That is where the kidneys come into play, because the kidney now have to say, hey, you are giving me all this fluid. We need to leave. We need to get rid of this fluid. And that is where we have GFR. And we need to know how we evaluate GFR in order for us to see how the kidneys are functioning. Kidneys function via three main things that we could examine. We could see the GFR, we could see renal blood or plasma flow, and we could see a filtration fraction, right? I'm going to explain how that happened. So the GFR is how much filtrate is being filtered through the glomerulus at a given time. That is what the GFR is, right? Now, the reason why we do that, if the GFR is normal, that is telling me that the kidney is filtering the right amount of solute at the right amount of time that it's supposed to do. Anyhow, the GFR falls, it's telling me the kidney is either sick, all right? If the GFR increases, it tells me some process is happening that is causing the kidney to overwork. And then we have to figure out what it is, right? Good. So the first, and then the renal blood or plasma flow is the amount of blood getting into the afferent arteriole at a given time, right? And the reason why we need to, the amount of blood entering and leaving practically. Because if let me say 5 mils of blood comes in and 5 mils leave, something is wrong. You understand me? The amount of blood entering a glomerulus should not be the same amount of blood leaving the glomerulus if it is filtering properly. You get me? Right. So if 5 mils enters, 5 mils not supposed to leave. And even if that 5 mil does leave, it's supposed to be more concentrated, less concentrated, than it entered, because some things had been filtered. Right? So when we look at that, we say, okay, something is happening with the kidney, something is not working. Right? And then we have filtration fraction. And what the filtration fraction does, it looks at the amount of blood coming into the kidney, and it looks at how much things is being filtered and seeing if it matches up. So for example, if you have 5 mils coming in and then 2 mils being filtered, right? You have to work out that ratio to see if it makes sense, because you can't have this whole heap of blood coming in. For example, you have 5 mils coming in and only 1 mil of that is being filtered at a particular time. That's going to tell you that the kidney is not working, because 5 mils of blood coming in but only 1 being filtered, the fraction, the filtration fraction would be off. And those are the things that we use to normally navigate, right? Unfortunately for us, we cannot measure renal blood flow, filtration fraction in Jamaica, right? But we have GFR. But I bet you they're going to ask a question on filtration fraction, because they're supposed to know about it, because it's one of those markers. All right? And it's something. So how do we measure GFR? Now, GFR could be measured by a theoretical approach, and there's also a clinical determination that you need to know, the plasma concentration of solute and urine flow, right? So for the clinical determination, we're going to leave that aside for now, because this is more practical, but we're going to look at the theoretical approach. Now, do you think that fluid just moves into the Bowman's capsule and drop out, and then do you think it just move in and drop out and then move? No, there must be something. And that is why we have to now understand the pressures that are at play in the Bowman's capsule. There are two main pressures. There's oncotic pressure and hydrostatic pressure. And we need to know how those two work, especially when we come on to certain disease processes. Because when you have a particular disease process, you have to know how that is going to affect the kidney. For example, multiple myeloma. We're going to come to that in a second. So the two forces are hydrostatic pressure, oncotic pressure, obviously, and the changes in any of these pressure would change the GFR. So if I increase the hydrostatic pressure in one end, it is going to push fluid into the place that has low hydrostatic pressure. If I have a lot of solute in this end, it's going to pull fluid in the other direction. So remember, oncotic pressure deals with the solute, mainly protein. Which protein is abundant in the albumin? So that is why albumin is so very important. And this also happens in the interstitium. When you have things like multiple myeloma, and when your kidney not working to filter out that extra protein, that is why you have third spacing, right? But that is for a different time. But I just want you to know, in the Bowman's capsule, these two pressure are at play. Now look at my little diagram here of my thing. The other thing that you have to understand about how filtration works is the afferent and the efferent arterioles. Based on them dilating and constricting, they are going to allow more or less blood to flow, and then that could increase or decrease the GFR. All right. And also, if we dilate the afferent arteriole, it's going to have a higher renal flow. Remember that renal blood flow. More renal blood flow equals increased GFR in a normal kidney, right? If I constrict the efferent arteriole, more blood circulates in the glomerulus, and it's going to have a greater filtration, right? So those are the things that you have to keep in mind. But let's work out how it goes. Could you see my cursor? Everybody online could see my cursor, right?
Yes.
Yes, doc.
Great.
Yes, sir.
So this here is your afferent arteriole. Afferent arrives, right? It arrives at the glomerulus, and efferent exits, right? Now the afferent arteriole coming in here brings blood from the body, from the body circulation to be filtered. And then when it's filtered in the glomerulus here, in the Bowman's capsule rather, it then leaves here. Now, if I dilate the afferent arteriole, what is going to happen to my plasma flow? It increases naturally, right? And if I have more blood coming into the glomerulus, what do you think is going to happen to the GFR? But why would it increase? Not necessarily. Remember I said to you that blood just, which pressure is going to increase? Hydrostatic pressure is going to increase. Do you understand? More blood coming in, more fluid coming in, and that hydrostatic pressure is going to increase in the capillaries, and it's going to force liquid out. It's going to force that fluid out, right? Now, the next thing I could do is constrict the efferent arteriole, right? What is going to happen to the renal blood? What is going to happen to the plasma flow? No. It's going to remain constant. It's the same amount of blood entering the space, just less leaving. Now, what is going to increase? Same hydrostatic pressure, because you have a backup of fluid now before that, and it's going to increase the pressure. So that is the two ways in which the body try to increase GFR when you have, like, if you pee a lot, when you drink a lot of water and you need to pee, this is what is going to happen. You get that? Right? Now, but what you also need to know is that you could have hydrostatic pressure in the Bowman's capsule as well. What do you think would cause an increase in hydrostatic pressure in this Bowman's capsule here? Inside here, what do you think would increase hydrostatic pressure here? What disease process? Huh? Go ahead. How about renal calculi? If you have a renal calculi in the distal ureter, it's going to back up that urine so much that eventually the hydrostatic pressure in the Bowman's capsule is going to be higher than that of the capillary. And then that is how people get hydronephrosis. Right? That is how the patient gets hydronephrosis. People with posterior urethral valves, same thing. Right? If I have a decreased GFR, I have to figure out, is this because of my GFR? Is the GFR limited because I have either some problem from the systemic problem, or is it something from the ureter? Is it something from the kidneys? You understand? So that's how I want to think about it. So the first one is the first thing that we could do is dilate the afferent arteriole. Dilating the afferent arteriole, more blood rushes into the glomerular capillary, and that will increase the renal plasma flow of blood flowing through this capillary, and this will also increase the hydrostatic pressure. When you increase the hydrostatic pressure, more fluid is pushed out into the Bowman space, and you filter that. Good. Then we could constrict the afferent arteriole, and what happened is that if we constrict the afferent arteriole, hydrostatic pressure also raised because we have the same amount of blood coming in, less leaving, increasing hydrostatic pressure, and then as a result, you're going to have increased GFR. Now, I want to talk about increased oncotic pressure. So what if we change the oncotic pressure in the capillary? What is going to happen? It's going to decrease the GFR, correct? But the body is so smart that if it has increased amount of proteins or thing in the capillary, the GFR is really not affected that much. It's weird. I don't know how the body does it, right? But that is the same. I want you to remember that concept. All right. Now, if we raise this pressure, that will draw more fluid into the capillary and resist the movement of fluid out of the capillary, and that's going to reduce the GFR, right? In general, changes in protein does not really affect the plasma flow, though. All right, so the plasma flow is not going to be affected. The same amount of fluid is going to be coming into the space. In other words, blood continues to flow through normally, and it's just less of it moves across the basement membrane into that. Which disease process you think you could find this in? Anybody? A high oncotic pressure in the capillaries. Multiple myeloma. What is it? What do you have in multiple myeloma? What do you have? Increase what? Hydrogen. Right, but you remember those benzones protein? Those benzoate proteins are disgusting. They're everywhere, and they are going to increase the oncotic pressure in, and that's why you have a decreased GFR in a patient with multiple myeloma. All right, it looks like kidney, and then those benzones protein then goes insert itself and cause a AKI, and then that AKI in of itself then destroys the kidneys itself, and then you have this. Well, obviously, you have a decrease. You have the patient have to go for dialysis and stuff. As soon as we get rid of the proteinuria and we get rid of the benzones, they don't no longer, the output comes right back to normal. They don't no longer need any dialysis. It is literally just the protein that is doing the problem, right? We went through hydrostatic pressure again, and I told you that if you have a hydrostatic pressure buildup in the Bowman space, it's more than likely due to some calculi. And then now, how does the body auto-regulate? The kidneys can do this, what we know as autoregulation. And this can maintain a constant GFR and the renal blood flow. Because think about this, your blood pressures are not stable all the time. It fluctuates. So when the blood pressure is high, the afferent arteriole will constrict to decrease the amount of pressure coming in, right? When it's low, it's going to dilate to increase the amount of blood pressure so that the kidneys could always, so that's why you have a constant GFR, but your blood pressures don't have to stay constant. You get me? Now, there are two ways in which they do this. They have a myogenic mechanism and something called a tubular glomerular feedback. So what happened in the myogenic is that when the arterioles have this high pressure and they start to stretch, it's going to send a message to say, hey, yeah, we're having high stretch. This means that blood pressure is high. We need to constrict, and the afferent arterioles are going to constrict. And in the tubular glomerular feedback is where you have more. So if you have a higher blood pressure, you have more fluid going into the Bowman's capsule. And one of the things that is filtered is sodium. The more sodium goes in, the macular denser cells in the distal convoluted tubule, in the JG apparatus, then becomes aware of that and then send a signal to the afferent arteriole and tell them constrict. I'm getting too much sodium. That tells me that I'm filtering a lot of things at the Bowman's capsule. More than likely, the pressure is high. So that's the tubular glomerular feedback. So those are the two feedback mechanisms that you need to know. All right. Now, these only work to a point. If a patient is severely hypotensive, it's not going to work. It could work so much and no more. And if a patient is severely hypertensive, it could only work so much and no more. Right. So it has to be within a normal range of blood pressures for the kidneys to work properly. All right. So what are the two? Tubular glomerular. All right. Now this is so if you look at my screen here, this is the afferent, this is the efferent, and then the coming in. So when the efferent, when a lot of blood pressure comes, when a higher blood pressure comes, the myocytes are going to dilate or stretch, and then it's going to have a reflex from the renal nerve, well, from not just the renal nerve, but the plexus, and then that is going to cause them to constrict and decrease the amount of pressure coming into the Bowman's capsule. Where you see the macular denser cell in the distal convoluted tubule, which is part of the JG apparatus, when that sends the amount of sodium that's coming in because of how much is being filtered, it then sends a message to the afferent arterioles to tell them, hey, you need to constrict. A lot of sodium is coming in. We need to keep this under wraps. Everything so far is clear. So far we have gone through the fluid compartments, and I've shown you that the fluid compartments, how we move different stuff, how we resuscitate. The reason why I started with that is so that we could segue into the fact that pressures are important for the kidneys to work. They use pressures every day to try to figure that out. How do we do that? And they also use pressures to do GFRs. The reason how do we measure the kidney function? We use GFR, plasma flow, or red blood flow, and a filtration fraction. How do they do that? Oncotic pressure and hydrostatic pressure are the driving forces of those GFR, right? So if the pressure is high, it's going to increase hydrostatic pressure. Then the renal is going to they have some autoregulatory mechanisms to help to counteract that, because the GFR is not supposed to go too high and not fall too low. If the patient have a disease process like multiple myeloma, then they're going to have high protein. The protein is going to cause it's going to hold on to the water, and then as a result, GFR is going to decrease. All right. So I just wanted to get a brief overview. This is just going through nicely, because when it comes on to the disease process, something like nephrotic syndrome, you have to understand oncotic pressure, because nephrotic syndrome is what is the oncotic pressure is the driving force of nephrotic syndrome. All right. In the distal, I went through that already. Now we're going into the nephron physiology. Now this part is where the bright people them run, because a lot of people do not like this part. So I'm going to take my time, and we're going to understand nephron physiology. And this is why I wanted everybody to come to this class, because this is your bread and butter of acid base. This is your bread and butter of adrenal insufficiency. This is your bread and butter of cardiac problems. Everything comes from nephron physiology. And if you don't understand it, you would never understand most things in medicine when it comes down to how we're treating patients. All right. All right, so the way the nephron selectively reabsorbs solute and other substances that are useful to the body is by transporting them from the urine into the nephron and then back into the interstitium. This is why we need those. Let me start. All right, so we have a, let us say, this is a, I don't think you'll be able to see it. I have a lot. I'll just quickly explain it afterwards. So we have. So what this is. So this. Let me say we take a cross section of a nephron. We have a. This side is where the urine pass. We have cells, and then we have an interstitium, right? The kidneys move things that is important into that direction. And what we don't want, we pass it into this direction, into the urine, so that you okay? I think I have another slide. Now, how they do this, how they do that is that the kidney would let go a lot of solutes, right? The kidney is going to let go a lot of solutes and then reabsorb what it needs. So it's like it's saying, okay, I'm throwing out all the garbage, and then you're going to come and sort through what you need. All right? Where's my mouse? No, but it's not moving. Moving now. All right. So we were here. So the cells of the nephron are polarized, and it has two parts. There's an apical membrane and there's a basolateral membrane. All right. So this part here is the apical membrane, and this part is where the urine is. And there's an interstitium of blood on this end where this interstitium where the blood is, where the blood and the capillaries are passing back, right? Now, how the what do you call it, absorb this is how it does this is via several ways. There could be specific proteins channels where it just carries the solute that in particular we're using sodium here right now across into it from the urine into the stuff. Then it could also take it could use an ATP driven, hold on, wait, we'll turn it off. I just pressed off. I mean, it can be like, if you're cold, you can turn it off for now. It's fine. Is this okay? Okay, turn it off for now. Okay, that's fine. All right, so they can use a ATP-driven channel, and it's going to use energy, or you can use a certain normal channel. And I'm just using sodium for example in this case, okay? Then you could also have free-flowing channels where it just goes over by diffusion from a high concentration to a low concentration, and then they could go through a paracellular route. Everybody else online hearing me? Understanding what I'm saying?
Yes, Doc.
With these three, okay. Then you have an osmotic diffusion where water would follow a particular solute, more than likely sodium, and then where you have also an osmotic gradient again, osmolarity comes into play. It's going to move to area of high concentration or higher osmolarity. Okay? Now, the segment of the nephron, I hope everybody knows the segment of the nephron. We have the glomerulus, we have the proximal convoluted tubule, loop of Henle, distal convoluted, collecting duct. So we're going to go each segment step by step, and we're going to see how their physiology work. And the reason why we have to do that is because when it comes down to things like your loop diuretics, you have to know how they work. You have to know why you have a potassium sparing one. You have to know why you have hypokalemia. You have to know why the patient is hyponatremic. You have to know why the patient has have high calcium. You have to know all of these wonderful things. How are you going to know them? You're going to know them by the renal nephral physiology. First, I'm going to do it the proximal convoluted tubule. Now, let me tell you something. If you don't have a proximal convoluted tubule, you're dead, practically. The proximal convoluted tubule is responsible for the absorption of most of the solute. So if you don't have a proximal convoluted tubule, go lie down 6 feet under, right? This is the workhorse of the nephron. It absorbs more solute than any other part of the nephron. It reabsorbs 100% glucose and 100% amino acid under normal circumstances. Mind you, under normal circumstances, right? So a patient with a normal functioning proximal tubule going to have absorbed all of its glucose and all of its amino acids. In other things like bicarbs and chlorides, potassium, phosphate, and water, there is about 2/3 of those are reabsorbed. You get me? No, we're going to go into how the body does that. So this is a little schematic to tell you how it does it. 100% glucose amino acid, 67% about water, bicarb, and sodium chloride. Now, the proximal convoluted tubule, how it does this. So we start off with this little channel here, the sodium ATPase, the sodium potassium ATPase pump. Let me mix it up. This is the driving force. This is like the generator of the proximal tubule. What it does, it pumps sodium outside of the cells of the nephron into the interstitium, and it pulls potassium into the cells of the nephron. So what it's doing, it's setting up a gradient. It's setting up a high concentration gradient of potassium inside the cell, and it's going to set up a low concentration gradient of sodium inside the cell. And from that, it is going to use normal diffusion of concentration gradients in order to move different solids around. I just find that so amazing. You set up, it's like you almost set up the thing to work practically. So this is why if somebody has somebody who has malnutrition, they are also going to have an AKI because they're not going to be able to filter some of these because they need that a lot of ATP, and this proximal tubule is driven by ATP. A lot of ATP is needed for this, right? So it pushes potassium. So I want everybody to tell me now, where does the potassium go? Which cell? No, but what is that, sir? The nephron. It's in the nephron, right? It's moving it into the nephron. I want you to use the terms because if they could bring a question and they would say, because there are some things on the apical side and something on the basolateral side. Sometimes there's the same transporters on each side. So in the question, they could say the sodium potassium ATPase pump on the basolateral side, the sodium potassium pump on the apical side. Which side is it on? It's on the basolateral, correct. It's on the basolateral side. That's all you need to tell me. Once you say basolateral side, I perfectly understand that. Oh, you didn't see that part. Go back to the, I'm going back to that slide. Everybody understand that everybody online understood the difference between basolateral and apical membrane? Hello?
Yes, doc.
Okay, so this is the apical side. You see the lumen? urine is passing in this side. So say this was the collecting duct here. Right, well, this is the really proximal tubule. This is where the urine is passing on this side, the apical side, and the basolateral side is where the interstitium of the tissue is that is going to take all the things that is reabsorbed. Right?
Yes.
Good. Diffusion, osmotic diffusion. All right, good. So we're back here now, right? So I wanted to first understand this part. This is step one. Step one, create a concentration gradient. We're going to create a concentration gradient of sodium and potassium. Step two. Now we have a lot of sodium leaving the cell, right? We have all this nice concentration gradient that was created, a low one, in the cell of the nephron. The sodium in the urine now wants to move in to the nephron, right? But it could only do so if it goes through a co-transporter, and that co-transporter is with glucose. So while we create this sodium, low sodium gradient to pull sodium from the apical side, from the urine, sorry, what is going to happen is that glucose is going to piggyback on the sodium. But what is going to happen is that if we don't get rid of the glucose fast enough, we're going to increase that, and it's going to put that pump at a halt. So you notice on the basolateral side, there's also another glucose transporter pushing the glucose right back out, so that we have a constant flow moving constantly. And this is why 100% of glucose is reabsorbed. We understand that? So if you ever see glucose in there, that means something else is wrong. I'm going to come to that. If you ever see glucose in anything, you should never ever see glucose there. That means that your glucose sodium transporter is affected. And this pump, that sodium glucose co-transporter, is where your SGLT2 inhibitors act. And know it, put it in the pipe and smoke it. If they ask you, where in the nephron does SGLT2 inhibitor semaglutide work? It works in the proximal tubule. You understand me? Don't mix it up, guys. So again, first we create a gradient to bring sodium in. We have a low concentration gradient inside the cell. Now it's going to want to bring sodium in the urine, now wants to move inward. But when it's moving inward, the only way it could work is if it comes through the only way it could work is if it comes through the the only way it could work is if it comes through with the glucose, and that's how we get glucose coming in there. Again, remember the SGLT2 inhibitors work on that sodium glucose co-transporter, right? So now that is glucose, right? We have now taken glucose. How do we move potassium, right? Remember that we're pumping a lot of potassium inside the cell. Remember, we pull potassium in, but the only reason why we did that is that we want to create a high concentration of gradient of potassium in the cell to move chloride out. So if you look on the basolateral side, you see that chloride has a co-transporter with potassium. But remember, because we have pushed so much potassium into the inside of the cell, the concentration is now high, right? That now the potassium wants to move out. But the only way the potassium is going to move out is if chloride is also hitchhiked on it. That is going to create a low concentration gradient for chloride. And that is when chloride is going to move inward, right? Because now we create a low concentration gradient in the cell for chloride. Chloride in the urine would want to move inward. Now, when you have things like bicarb and the other anions that the body doesn't want, we need to excrete it. But the body doesn't have to use energy to do that because it has to hitchhike on the bitransporter with the chloride. So when chloride moves in, anions move out in that same from that same pump. Everybody clear with that? So far we have gone to see how glucose was absorbed. We see what happens to potassium. It increases the potassium in the cell so that the potassium would want to move out eventually. And by doing so, when the potassium is moving out, chloride, it has to do that with chloride, creating a low concentration gradient for chloride. And then chloride in the urine would now want to move inward. But while the chloride is moving inward, it needs an anion to move outward. And that is why you're going to have anions moving outward. We talk about the bicarb and so forth and so forth, all right? Now the anions are negatively charged substances that have a tough time getting across glomerular capillary membrane, and they often don't get filtered very well, right? So what happened is that when the anions that come at the glomerulus, because it's negatively charged, they're going to repel because the basement membrane is negatively charged as well. So it's going to go all the way around, and then it's going to be in the interstitium. So what the body does, it pulls it from the interstitium and then use the chlorine anions transporter and push the anions out while it pulling the chloride in. You look lost. Yes. So yes, so it passes into the interstitium and it moves in the opposite direction. Remember this little diagram I said when the body don't want it, so it's trying to go to the lumen, right, into the urine, but it can't get past that membrane again. It needs a channel, and that channel is a chloride ion transporter. So for every time chloride comes into it, an anion moves out, and that is how we excrete anions and bases in the urine because of that that transporter. All right. No glycosuria. If a patient develops high glucose concentration in the serum, as occurs in diabetes, if it gets above 160, it's going to oversaturate. Remember, all the glucose is going to be filtered in. So if a patient's serum glucose is 160, it's going to filter all of that 160, and then it's going to overwhelm which channel is going to be overwhelmed. Very good. That is going to be overwhelmed, and then some of it is going to be lost in the urine. That's the start of when that happened. When it reaches 350, you're going to have typical diabetes, because you're going to have, and that's why it comes diabetes insipidus, not insipidus, diabetes mellitus, because your urine is going to taste so sweet. All right. In pregnancy, however, it's normal to have, because the GFR increases in pregnancy, and it's also, and what happened is that not all the glucose is reabsorbed. So it's normal to have a little bit of glucose in pregnancy. That is why we don't do a urine test for diabetes in pregnancy, because you will or you might have some glucose in it. So you have to do a serum test instead. The OGTT is the gold standard for that. What happened? You're right. Remember, you have an increased GFR, and also that they expect. That's what they expect in the that's what they expect. All right. All right, so next one. So the bicarb now. So we need bicarb. We don't really want to get rid of all the bicarb, because we need bicarb to, we need bicarb to help with the, the acid base kind of thing. Well, hold on. Brianna. Okay, we need the bicarb to help with the acid that is produced every day. I'm just gonna go to this slide with the acid because it's gonna make sense. Hold on, somebody said something. All right, good. So what happens is that there's a sodium hydrogen bitransporter, right? Every time sodium moves in, it pumps out a hydrogen ion into the urine, right? When that goes out in the urine, it combines with bicarb, and that bicarb forms HCO3, carbonic acid. Then we have an enzyme, carbonic anhydrase, then splits it up, and then it creates carbon dioxide and water, which then diffuse into the cell. right? And when it diffuses into the cell, it goes through that same process where carbonic anhydrase then reverts it back into carbonic acid, which then dissociates into hydrogen. The hydrogen then goes out now and reabsorb the bicarb, and then that bicarb now could go out to be used. So that is why when you have acidosis, we look to see, is it the kidney that is at fault? Let me check the bicarb. That's how we know if it's a metabolic acidosis versus a respiratory alkalosis. Because if the kidney is not working, we cannot reabsorb that bicarb. And then acidotic process is going to take place. You understand me? Now, if we know that it's a compensated, the kidney is going to increase the amount of absorption of that bicarb, and to have a higher bicarb normally, right? So you understand. And the reason why I'm saying is when we do acid base, we have to remember these. We have to remember about renal tubular acidosis and all of those wonderful things, which they don't really teach anymore. I don't know why, but they ask questions about it all the time, right? Now, Fanconi syndrome.
Doc, could you go through it one more time, please?
Sure, no problem. So we have on this side, this is the urine side, correct? So the patient is losing bicarb, but the bicarb is very important to help us in order to neutralize the acid that the body makes every day. You understand? So what it does is that it creates a low concentration sodium gradient inside the cell here, correct? So sodium would want to move in, but every time sodium moves in, the channel that sodium could also move besides the glucose, which pushes hydrogen into the urine. When it does that, the hydrogen is going to combine with the bicarb to form carbonic acid. Carbonic anhydrase is going to break down that carbonic acid into carbon dioxide and water, and that is then going to be reabsorbed by the kidney, by the nephron, and then another carbonic anhydrase inside the cell going to recombine the carbon dioxide and water to carbonic acid. That carbonic acid could now be diffused, could be dissociated, sorry, to form another molecule of hydrogen and another molecule of carbon bicarbonate. Now the bicarbonate is then pushed into the interstitium so that it could go and neutralize all the acids that are in there. And then that hydrogen is reused again to capture another bicarb. So you see that bicarb out here? It's this whole process is just a capture bicarb to put into the interstitium. You get that?
Yeah, I understand.
Great. So, and then again, this is important for us because this is what is responsible for all of our bicarb stuff, that all of our acid-base balancing. So that's why when we're looking at it, we're looking to see at the bicarb to see if it's a metabolic acidosis versus a respiratory acidosis, if it will be carbon dioxide, okay? And then we look to see if it's compensated or not. Now, Fanconi syndrome, it presents very similar to diabetes. You're going to have high sugar, you're going to have glycosuria. The difference is going to be, though, there's going to be normal serum glucose. In Fanconi syndrome, what is going to happen is that the patient is going to lose function of the proximal tubule. So they're going to end up with a lot of things. And the reason why I put this in here is because sometimes you would get this in the exam and you would quickly put diabetes mellitus. But when you look at the bicarb value, when you look at the values, you're going to see a normal serum glucose, and you're going to see everything in the serum normal, except when you look into the urinalysis, you're going to see, but boy, there's a high glucose. You would also see non-ion gap metabolic acidosis. Why would see a non-ion gap metabolic acidosis? Remember that I just said to you that the proximal tubule is what used to recycle the bicarb. If the proximal tubule is not working, you cannot reabsorb that bicarb. You're going to leave all those acids to run free, right? Also, you're going to end up with a hypokalemia. You're going to end up with hypokalemia. The reason being is because you're going to have you're not really going to be reabsorbing any of those, right? And then what are the cause of that is lead poisoning is the most common acquired cause, right? Multiple myeloma, again, is another cause of Fanconi syndrome. And you see all those drugs are put in black below, all of those are associated. And you have something that you'll see a lot of time. Cisplatin, isofossamide, tenofovir, which is what? Exactly. So patients who have HIV and antiretrovirals also could develop Fanconi syndrome, and you have to look out for that. All right. Valproic acid. Where do you use valproic acid? People who have, exactly, my friend, anybody who is on it and they come with a glycosuria, but a normal thing, think Fanconi syndrome. Aminoglycoside antibiotics, who is on that? Nearly everybody, right? Deferoxamine, which is what you use to chelate, and all of that can cause Fanconi syndrome. And that is why I put it, that's why it's important. Right. Okay. Right. Fanconi syndrome. Now we are going to move on to our descending. So anybody, any questions on the proximal tubule? I promise you that was the hardest one. That was the longest one. Do you understand everything? And remember which one is it? What is it driving? What is the powerhouse of the proximal tubule? Huh? Right. You have to say where it is on the basolateral side. What does that do? You have to tell me what type of gradient. Huh? Right. So it creates a low concentration gradient sodium in the cell and a high potassium in it. What does that low sodium does? You say what? Right. 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 Maybe have a high gradient. So it's the sodium. Which one? Where are we? So remember the potassium is high in the cell, right? Guys online, y'all are hearing me? Remember the potassium is high in the cell, and then when the potassium have a high concentration gradient, it's going to want to move back into the interstitium. When it's going to do that, it's going to bring the chloride with it, decreasing the chloride gradient, concentration gradient in the cell, which is going to want the chloride in the urine to move inward. When that chloride is moving inward, the anions are moving outward. All right, good. Also remember there's a sodium hydrogen bi-transporter. Every time that the sodium moves by transporter, every time the sodium moves in, hydrogen is pumped out, hydrogen combines with carbonic anhydrase, then splits into carbon dioxide and water, that moves back into the cell, and then that code, that all that is just to get that carbon, that bicarb to go into the body. You get that? I hope that this should not be able to confuse you at all. Chloride bicarb, sodium. There's no chloride. Oh, no, potassium chloride. Potassium, right? Potassium chloride on the basolateral side, correct? There's three main ones that start. There's only one really started, This is the sodium potassium ATP pump. And when that create those gradients, is then everything is hitchhiked off the gradients, right? You notice. So that's all that's going to happen. And then one of the high yield things that you need to know is Fanconi syndrome. because it looks like diabetes, very common thing in Jamaica, but it's not diabetes. And then they also have to look for the hyperkalemia, the hyponatremia. They have to look for all of those wonderful things that is going to happen when they have a Fanconi syndrome. All right. Now let us go to the descending loop of Henle. Right? In the descending loop of Henle, we have, that is the next part. I wanted to look, everybody could see this cross section of the kidney, right? This is the cortex out here. And then you have the medulla. And you have an outer and inner medulla, actually. You have an outer medulla and an inner medulla, right? So if you split the medulla in half, you have an outer medulla, inner medulla. The loop of Henle dips from the outer medulla all the way down into the inner medulla, right? And then back up. And you have to understand what is the problem, what is the purpose of the loop of Henle. The loop of Henle is sole purpose is to reabsorb water, right? So it is impermeable to losing sodium chloride. Sodium chloride is not going to be lost, but it's permeable to water, right? But you're going to say, but Doc, how is it going to move water without sodium? Something must happen. Well, apart from the aquaporins, it needs a high osmolality. Remember I mentioned that before? That's the only way we're going to move water in and out of the dish from fluid compartments. No, the forces that drives it is based on those. So what happens is that the body creates a very smart way of doing it. So look at the cortex. In the cortex, what is the osmolality of plasma? 300. So you see in the cortex, the 300, you cannot move it. You can't move fluid across them because you notice the cortex has the same osmolality, 300. So in that part, you have to have your hydrostatic pressure, you have to have your oncotic pressure, and all of those wonderful things happening. But look at what happened when you go into the outer medulla. When you change the outer medulla, look at the osmolality. It did what? Where is water going to move? Inward?
Oh,
No, tell me, where is the water going to move?
all enough into the vasculature.
So remember we're looking at the loop of Henle now, eh? So in the loop of Henle, which starts here, after we pass the proximal convoluted tubule, the loop of Henle, which starting down here, water is going to move to the place where you have a higher osmolality, because remember, osmolality is what is the amount of solutes in the amount of solutes, right? You get me? Right. So water is going to move into the direction of the higher osmolality. So it's going to move into the interstitium from the urine. I don't think you're getting this part. My batch. That is the, so let me go back. So let me go now. It's probably, so the 600 milliosmol is the interstitium, is outside of the tubule, is not inside the tubule, right? Right? The urine is still 300 milliosmoles, right? The urine is still 300 milliosmoles, but the outer medulla is 600 milliosmoles. I wish everybody was in person today. I could probably show you what. So again, guys, remember, what does osmolality mean? What does osmolarity mean? Right, it measures concentration, measure of solute. Where would water move? Water move from an area of? Exactly, water would move from a low concentration area to a high concentration area, or a very dilute solution to a concentrated solution. If something is 300 milliosmol versus something that's 600 milliosmol, where would the water move to? It would move to the 600. The urine coming from the cortex is 300. The reason why it wasn't moving in the cortex, because the cortex is also 300. When it comes down to the outer medulla, it is 600. So now the water is going to move. And remember how God made it so smart is that sodium is impermeable, but water is not. So the only thing that is going to leave the urine at that time is water. And it gets even, this is how we concentrate the urine. I was waiting for somebody to say it. This is how we concentrate. When you don't drink water and every day and you come and you pee yellow, is your loop, thank God for your loop of Henley. Thank God for your loop of Henley. That is what is doing that. It's concentrated, it's taking out all of that water to reabsorb it. And it gets even worse. Look at what the milliosmolar falls to at the inner medulla. So the urine is still at 300 versus that at 1200 milliosmol. Right? So you see how it's going to really dip it a bit much when it reaches down to that part. Right? And that's all I really need to know for the descending limb, right? Just know that it's not permeable to sodium chloride, it's permeable to water, and because of the increasing osmolality in the interstitium, it's going to reabsorb all the water, concentrating the urine. You understand that? Good. Now, the ascending limb is the opposite. It is not permeable to water, but it is permeable to sodium chloride. So the ascending limb is the opposite. It's impermeable to water. However, it is permeable to sodium chloride, which means that as the urine moves up in the ascending limb, sodium chloride is going to be removed, and this is going to pull solutes out of the tubular fluid and dilute it all the way down to 120 milliosmoles. Right? This is if you need water. So the ascending limb is going to now reabsorb sodium chloride. But not only that, it is such a smart thing. There are two parts. There's a thin ascending limb and a thick ascending limb, right? And in the thick portion, it's important that sodium chloride is actively reabsorbed to take the tubular fluid all the way from a very dilute to a low osmolality of 120. So it dilutes it very, very much, because remember, it's going to move the sodium, and water is going to move in, coming from a low concentration gradient, coming from the concentrated thing from in the loop, the descending limb, right? Sodium and chloride reabsorbs to thick ascending limb and pumps back. Henley, very important, pump, absorb. Right. So now, in the top, there's this transporter at the top. In the thick ascending limb, there's a sodium, potassium, and 2 chloride. This is the pump that our loop diuretic works on, right? Because when you have a loop diuretic, if the loop diuretic works on this, is going to cause you to waste the water, well, practically waste the sodium. And then, however, this is not where you lose potassium. Remember, you have a risk of losing potassium. It's not at this. So you notice here, right? In the let's see, in this urine, where is it pulling? Where is it pulling the sodium? Right, from the lumen. If the loop diuretics inhibit that, it's going to do what? It's going to just leave the sodium to go right past. You understand that? And that sodium is then going to pull water with it. And that's how the loop diuretic works. What happened? So you notice where it's pulling, where the sodium is pulling. It's pulling sodium from the urine, right? Remember the urine is now so concentrated with sodium because from the descending limb, right? What it's going to do now, it is going to inhibit that channel, right? And when it inhibits that channel, all the sodium is going to bypass and go to the collecting to be wasted. And when it does that, it's going to pull water. Remember the thick ascending limb is permeable to water and not correct. No, a lie, it's the other way around. It's permeable to sodium, sorry. Right. And when it goes around to the collecting duct, it's going to pull water from the aquaporins. Right? And that's why it's called a loop diuretic. It's going to make you pee a lot. Right? Do you get that? Right. It's about the sodium in this state, right? And that's the thick ascending limb. What it also does is that it pushes potassium outside into the lumen and increase a concentration gradient for a positive, it increases the charges outside. And because there's so much positive charge outside, they're going to move inward. And that's why you're going to absorb magnesium and calcium by the paracellular route. You understand that? So it's going to push potassium outside. And then when that potassium outside go with the positive charges, all the positive charges are going to move to the lower concentration gradient, so your magnesium and the calcium. You get me? Right. So when they go out, there's too much positive charge and they're going to try to dissipate. Because if you put the positive and positive together, it's going to repel and it's going to move it into the lumen. And that's the purpose of the thick ascending limb. Where is the calcium and magnesium reabsorbed? In a thick ascending limb. Where sodium is impermeable in the ascending limb while water isn't. Am I saying that correctly? I'm probably tired, but anyhow. I think I did. It's permeable to sodium and not water. The sodium is the opposite, right? Okay. Now the distal tubule, this part of the nephron reabsorbs sodium chloride again, right? And the ATPase pump is that reabsorb the sodium is exchanged for potassium. This creates a low concentration gradient of sodium in the cell, and that low concentration of sodium is used to reabsorb sodium and chloride. The chloride can then diffuse out of the pump on the other side of the cell. And the distal, so you remember we pull all that calcium before in? See that calcium that's going outside there now on the basolateral side? That's the side that the PTH, the parathyroid hormone, works on for reabsorption. So remember, so that is it. So it works in the distal. So the PTH works in the distal, the SGLT2 works in the proximal, the loop directrix works in the thick ascending limb, and how do we reabsorb all those other things from the calcium and magnesium, the electrolytes, and that is why we check our electrolyte balances to check kidney function as well, UNEs, because we can see all of that. Extended UNEs, exactly. So we see how important the kidney is. And this is why I always start with this, because you cannot do renal and not understand the backbone of all of this. Everything would make a lot of sense eventually when you come to the disease process, when you understand. When you talk about a type 2 renal acidosis and a patient has adrenal insufficiency, why is the patient having a non-iron gap metabolic acidosis? Because they realize that, hey, aldosterone caused this on this leg, and this is what it's going to cause. You'll thank me later. Now, the collecting ducts have two types of cells, principal cells and intercalated cells. And the intercalated cells, the principal cells, have an ATPase pump that generates a low concentration of sodium inside the cell. In this manner, sodium can be reabsorbed by the principal cell via a channel. The channel is called the ENaC channel. And the ENaC stands for epithelial sodium channel and is activated and regulated by aldosterone. So let's go to this here now. So you see that ENaC channel? So what happened is that, again, on the basolateral side, you notice that that ATPase is pumping sodium out, creating a low concentration gradient. Now we have an ENaC cell, we don't need a co-transporter. That ENaC cell is going to bring sodium back in, right? Then potassium is moving out as freely, and the water is also going to follow as is. The intercalated cell, is all it does is excrete hydrogen ions, right? So let's know that. So the main role of the intercalated secrete acid, we know that. Anytime there's an increased sodium delivery to the collecting duct. So let me show this. Now this is where we lose potassium with the loop diuretic, right? So let me show you. Remember this is the collecting duct, right? Where is the loop diuretic working? In which part of the kidney? I feel like I lost the people them online. Online, we still here?
Yes, doc. Still here.
Yes, doc.
Yes,
And you're understanding, we clear with what is happening?
Yes, yes.
I don't hear Noya and the others.
Okay, for me, I'm still trying to figure out the high concentrate, because I understood it up until the distal tubule.
The distal tubule. Let me go back to the distal tubule. So you understand up to here?
Yeah.
Which part you don't understand?
Because he said it reabsorbs it. So now I'm thinking, did the urine become, because the urine was first concentrated,
Right,
and then it became a little bit more dilute at the
right,
ascending. So is
right.
it that it became back concentrated at the stall because it's reabsorbing the sodium?
Right. So what it's going to do now, it's going to this collecting duct is going to determine whether you're going to be concentrated for real or
Mm-hmm.
not. Because if the body then comes back and say, hey, we need a little bit more water, it's going to reabsorb it and it's going to leave it. You understand? It's going to leave.
Okay.
So this is the final say, really, right? So the loop of Henry was doing its thing, getting its, concentrating the urine, blah blah blah, and then when it goes back up. But if the body say, yo, boy, we need some more water, we're going to have to pull back all the water. The collecting duct is going to be responsible for that.
Okay, I understand now.
Right. So what happened? Remember when that thick ascending limb, remember you're supposed to, the loop of Henle working on the sodium potassium chloride channel up there, right? If it inhibits that, it's going to let all that sodium, remember all that sodium that was there from when we concentrate the urine from the descending limb, all that sodium is going to come and pass and reach into the collecting duct. And when it reaches the collecting duct, what it's going to do is that, remember, there's a low concentration gradient in the cell already. If you have a lot of sodium moving into the cell, the ATPase, the sodium potassium ATPase pump is going to work faster. So the more sodium you're pumping out is the more potassium you're going to be excreting, and is the more potassium you're going to lose. And that is why you're going to be wasting potassium when you have a loop diuretic, because the loop diuretic is going to waste the sodium initially, but when it reaches down to the collecting duct, the sodium is going to cause you to waste potassium, and that is that's why it's not potassium sparing, like spironolactone. Not spironolactone. That's one that is potassium sparing. I don't remember which one it was, right? And this is what is going to happen. Is spironolactone? Oh, I'm hungry. Sorry. Right. So so you understand where you lose the potassium. It's in the collecting duct and not at the cell, right? So this is what happens here. And then your inner channel is going, and then the intercalated cell now is going to be pumping all those ATP, those hydrogen ions out. The main role of the intercalated cell is to secrete acid. We went through that, and more sodium. We went through that. Now we are at the last part of this, which we'll wrap up for today, which would be our hormones, the collecting duct, the aldosterone. We're going to focus on aldosterone. So aldosterone effects on the collecting duct. It can increase the number of sodium, potassium, ATPase protein. If that happens, what is going to happen? It's going to waste potassium and going to absorb more sodium. What system is aldosterone a part of? Very good. And what is the purpose of the renin-angiotensin system? Very good. And remember, sodium is going to move and pull water with it. So that's why aldosterone, if it's activated, it's going to increase those ATPase. So the more sodium it pulls is the more water it's pulling. However, we're going to lose potassium in that same light. And that is why if you have adrenal gland that's overproducing aldosterone, you're going to have hypokalemia. No questions asked. It makes sense now, does it? Right? It increases the number of ENAX channel in the principal cell. Again, why is it going to increase the ENAX channels? Because they want to reabsorb all that sodium and then pull all that water with it. But in doing so, it's going to lose all the potassium. It promotes potassium secretion by principal cell. If you are hyperkalemic, aldosterone is going to come in play because it's saying, hey, we need to get rid of some of this potassium. It's too much, right? So if you check somebody who is hyperkalemic, they're going to have high aldosterone at the time. Why? Aldosterone is going to cause increase in sodium potassium ATPase, and it's going to cause you to lose the potassium. The patient is hyperkalemic, right? So they want to get rid of some of that potassium. If it's want to get rid of some of that, all it needs to do, call it big friend aldosterone. Aldosterone is going to bring the ATPase pump, and the ATPase pump is going to pump out that potassium from the interstitium. We get that? You look confused. What happened? All right. Hydrogen ions secreted by the intercalated cell as well. right? So the intercalate, the aldosterone also secrete that. So that's why if you have adrenal problem where you have secreting, overproducing aldosterone, you're going to have a non-anionic metabolic alkalosis. The reason being is that you're going to be losing so much hydrogen ions. And why are you going to be that? Because this aldosterone is going to be pushing out the hydrogen ions with it. So the overall effect of aldosterone on the collecting duct is that it will increase the sodium and water reabsorption, and this will affect the circulating volume. And that is the whole purpose of this aldosterone, and that's why it does it. So look at here. So one is going to increase the sodium potassium ATPase form, is going to increase the sodium, right? And it's going to increase the sodium or the ENAC channel, and it's going to increase the hydrogen secretion. So for any time you get a hydrogen adrenal problem, you should be able to work out what the urinalysis is supposed to look like, right? And then the collecting duct, hence why aldosterone is part of the renin-angiotensin aldosterone system. The job of the entire system is to respond to low perfusion and pressures in the body, right? And what it does is that, hold on, right? It's supposed to present, and responsible for regulating serum potassium, and it will also promote an acid excretion. Its release is stimulated by mainly by the angiotensin 2 and by high potassium. So what happens is that when you have those the juxtagonal cells not getting the perfusion, it releases renin. Then renin starts the cascade, and then when it reaches down, they say, okay, release aldosterone because we don't have enough volume in our blood vessels. The aldosterone is then going to go to the collecting duct. It's going to increase the ATPase potassium pump. It's going to increase the ENAC cell, and it's also going to secrete hydrogen, and that is going to pull sodium back in, wasting potassium, pulling water. And then that water is then supposed to increase the vascular volume. And that is how we're supposed to raise the blood pressure. And now, you remember our problem with heart failure? We have congestive heart failure, right? And I'll talk about pro-BNP and BNP next class. When we come back, we have to talk about that, because what is going to happen is that when you have congestive cardiac failure, you have low cardiac output. The cells don't know that you have heart failure. So what is going to do in the kidneys, that is? So the kidneys is going to constantly fire in renin, but that renin is going to increase the preload, which makes your heart failure worse. And that is why patients who have heart failure are on ARBs and ACE inhibitors, because they need to stop the renin-angiotensin system. However, that in effect damages the kidneys. That is why renal and cardiology can't make up their mind who them want. And that is the problem, right? They're always in constant fighting because of this problem. And then what is going to happen? The pro-BNP is going to feel is going to get the stretch with the big preload, is going to release pro-BNP, but pro-BNP have a similar effect to that of aldosterone. So it is one bag of confusion when it comes on to heart failure. How do we manage heart failure? We have to know the hormonal pathway. You cannot come to here and not know it, because when you're going to manage a patient, you have to know. So this part is also important for you to know when you go onto the cardiology module when you're dealing with congestive heart failure. So guys, this is where I'm going to end this thing. Yes. So this is our renal physiology. Please go home, digest it, and belch it, but don't waste all of it. Go it over, understand it, know which channel is affected, know your SGLT2, which is high yield, because that's what they use, know your way a loop diuretic works, know how your aldosterone works. I'm going to create a handout from the slide, and then I'll send it afterwards with all the notes inside of it. I normally send it to the persons who actually did come to the class. I don't, because what was happening last year is that people weren't coming to the class and still getting the handout. I know this class sounds like a lot. I know you all waited and tired today. I'm very, very sorry about that. But what I will do, I'll try to see if I can have a makeup class. Lauren, so if you want to come to that class as well, it will be free. You don't have to, I'm going to do the same lecture. You could come to that class, and then I'll give out the handout, and we could have. And what I'm going to try to do is get have some questions on these and see if you could just to see how good you understand them. With this is not going to come in the MBBS slide. Which cell is no? You have to put it together. You have to understand all that is. So this is the baseline, and this is where we start here, and then we're going to build on top of that. All right. For when we build on top of that, now you'll know. Okay, a patient has low potassium, high sodium, but alkalosis. This sounds like a what problem? Aldosterone problem. So probably we should look at the renal or the arm or the and this is why I like to do renal and adrenals together, because they're so very, very closely linked, right? And then you're looking at this, a patient comes in with glycosuria, but the normal serum glucose. What else is wrong with this patient? I don't know. But then you hear the patient has HIV and was on tenofovir. What do you think this patient has? Fanconi syndrome. That is how you put the things together. You don't sit down in a vacuum. And this is how I teach. I do not teach, oh, let's practice past paper. No, I bet when you leave now, if you go out there and you see Fanconi syndrome, stand up in your head, you would know. Because when you look at the patient medication list, you see tenofovir, cisplatin, ifosfamide, any one of those, you'll be able to say, yo, this patient is at risk, no matter how rare, for Fanconi syndrome. Right? I was supposed to do the embryology module when we talk about the Wilms tumor and those kind of stuff that they're going to find. But I said, boy, I couldn't put all of it together. It's a good thing I never did all of it, but it's not something difficult. And the posterior urethral valve, when you talk about hydronephrosis and your pyelonephritis and all of those, when we jump to the renal calculi, this whole hydrostatic force thing is going to come back again, and it's going to realize, and it's like, oh yeah, I know what is going to happen. Patient, this how we're going to fix this, whatever. We know how that is going to happen. This is the baseline. So go home. Once you get this done, you should be good. And the thing is, guys, your colleagues do not know this. You're already 5% ahead than most of your colleagues because they don't know half of this. And it's sad to say, I only knew this coming down into MBBS, and I wish I didn't. I wish I knew it before, because it made renal a lot more manageable. It made me understand renal a lot more when I understood the basics, the backbone of what is happening. And that is nephron physiology. Yeah, so that is the backbone. I think my battery died. So that is the backbone of the stuff. Any question from anybody online?
No, doc, not from me.
Y'all understood? Was it clear?
Yes, doc. It's just to go over the stuff.
Okay. So I'm gonna take a screenshot of those who are here, and then I'm going to I will ask the others in the group when they would want me to do it. Again, if you want to come back to the I know it's kind of a lot sometimes to understand. If you want to come back, you can. It's fine. I don't have a problem. And then I have to try to see when I could do the embryology one, because that one. So the Wilms tumor is no surgery, but still it would help to understand the origin and to the metanephric blastema and see the different what is going to happen. Right, we have to go back to the embryological origin. So if there's no question, you could always message me, and then we could you could always message me if you have any question at all, and then we'll move on from there. All right.
Okay, doc.
All right, no problem.
Thanks, doc.
No problem at all.
Thank you.
Thank you for waiting.
Thank you, Doc.